Hello and good day to everyone. My name is Montes. I'm a fertility doctor in Bogota, Colombia. Nice to meet you. So today we're going to talk about ultrasound in the evaluation of ovarian and endometrial stimulation. To optimize the results of assisted reproductive treatments, recruitment of multiple follicles is often necessary, and this is achieved by controlled ovarian hyperstimulation. This makes the ultrasound relevant when you want to have the best results and a good outcome. When monitoring COS, clinicians need to be able to make decisions on when to start the treatment of controlled ovarian stimulation, evaluate the response to the medication, and decide when the response is not adequate and stop the treatment. The appropriate time for final oocyte trigger and assess the risk of ovarian hyperstimulation syndrome and consider some strategies to prevent its presentation. However, the need for intensive ultrasound monitoring is controversial because it's more time-consuming and expensive, and associated with greater discomfort for the patient. But given the benefits of ultrasound monitoring are well established and practiced worldwide, we should do our best to seek the best results by performing an ultrasound with the most appropriate methodology. Almost all conventional day 2-3 cycle ovarian stimulation protocols for ovulation induction, or COS, utilize early follicular recruitment in an effort to maximize or have the maximal or the best optimal follicle development, as well as to synchronize the oocyte development to a receptive endometrium. So to start a treatment, it is necessary to perform a transvaginal ultrasound on day 2 or 3 of the menstrual period, identifying antral follicles without evidence of cysts greater or larger than 12 millimeters, as you're seeing right here. Give me 1 second. Enter. As you're seeing on the left side of the screen. And the thing with this kind of cyst is that it might be producing estrogen. And when these cysts are producing estrogen and you start the medication, it will decrease the response to the treatment and lose endometrial synchrony. So when you see this kind of cysts, it's better to do a test to check the estrogens and not start the medication. What you must see on the ultrasound is a normal ovary with a lot of antral follicles, but not greater than 12 millimeters, as you see in on the right side of the screen. On the other side, the follicular wave theory proposes that multiple waves of antral follicles development during the menstrual cycle, not just once, or just one during the whole follicle cycle, but sometimes 2 or even three waves, as it has been seen in bovines and non-human primate species, which supports the theory for the random start treatment usually used in cancer-diagnosed patients, which don't have time to wait and need to begin the treatment as soon as possible. However, some studies have demonstrated that the random start doesn't have better results in terms of mature oocytes, but neither a worse outcome, as this study from Pereira et al., where they took patients with non-cancer diagnosis and randomized them between the moment of the COS start. As you can see, there is a control where the number of oocytes retrieved were 13.1. Another group of early follicular phase where 12.7 were retrieved. And patients on the late follicular phase where 13 were retrieved, and in the luteal phase where 13.2 were retrieved. But the number of mature oocytes were almost the same in the 4 groups, which means that it doesn't have better results if you start any day, but neither a bad outcome. But the thing is that when you do a random start, you lose the synchronization with the endometrium. So for just for the patients with cancer, it's better to do the random start. For every other treatment or type of treatment or type of patients, it's better to just start in the early follicular phase on day 2 or 3 of the menstrual period. So in order to reach an adequate pregnancy rate, it is necessary to have a response to the treatment, and this makes ultrasound necessary to determine the adequate follicular and endometrial response. In this slide, we can see how the follicular and endometrial behavior it's at the beginning of the menstrual cycle, where when the estrogen levels are very low, and you see the antral follicles and the endometrium that is very thin. The late follicular phase, where the endometrium is growing, and you see that the endometrium thickness is also growing, and you see the endometrium is trilaminar. And the follicle that it's in the preovulatory phase, and the ascending levels of estrogens makes a change in the response and the characteristics of endometrial thickness. As demonstrated by this meta-analysis performed by Gao et al., endometrial thickness less than 8 millimeters presented lower pregnancy rates, both in fresh and thaw embryo transfer cycles. For these reasons, we recommend that the endometrial follow-up and follicular response should be carried out within 5 to 7 days after the start of the treatment, looking for a follicular response where there is a follicle greater than 12 millimeters in low complexity treatments such as ovulation induction or IUI, and a leading follicle that exceeds 12 to 14 millimeters in COS treatments. The next question is when to trigger, and it will depend on the type of treatment you're doing. When your patient is in an ovulation induction treatment or IUI, where the number of mature follicles should not exceed a number greater than 2 or 3 dominant follicles, the diameter by at least one of these should be greater than 18 to 12 to 20 millimeters. In the case of COS, or patients during COS treatment, you must have at least 2 follicles greater than 18 to 20 millimeters, and they're called leaders. There is a question that arises for all clinicians who perform the ultrasound, especially at a technical level, since when we have a follicle with a circular shape, the diameter is easy to calculate because you just can trace it in any way. However, in patients where due to the position of the ovary or the pressure that you generate during the exam, the shape of the follicle is oval, and the way to calculate it is through the following equation. You take the 2 perpendicular diameters, they're added, and divided by 2. And this is an example. If you have a first diameter that is, I don't know, 20 millimeters, and the other one is 16, 16 plus 20 makes 36, divided by 2, and it makes 18 millimeters. So this follicle would measure 18 millimeters. Oh, it's easy to perform an ovulation induction treatment and treatment of IUI or a COS treatment when you have an adequate response, but it not happens every time. And the difficult thing is what to do when your patient do not respond in the correct way, either because her response is too low or when you have a response that is too much or excessive, as is the case of ovarian hyperstimulation or syndrome. This same question was asked by Shem et al. When they conducted a study with patients with poor response to COS treatment during IVF cycles, considering that a poor response was having less than 2 follicles greater or larger than 18 millimeters. And the answer will be mainly related to the age of the patient. Because as you can see on the right side of the screen, patients below 35 years old had a pregnancy rate of 35% and a live birth rate of 15.6%. In patients between 35 and 39 years old, the pregnancy rate was 14.7 and the live birth rate was 6.4. And patients above 40 years, the pregnancy rate was very low, actually 8.5%, and the live birth rate was even lower. So as you can see in this result, you have to talk with your patient, because in the next cycle you might have the same response. It's not that, okay, you did this treatment, this cycle treatment, and well, the response was not good, but in the next one you'll have a better response. It doesn't happen often. So you might have a similar or even a lower response. So before making a decision of suspend a treatment cycle, it is important to advise on the low chances of success and the possibility of not having embryos to transfer, and even the possibility of carrying out a new treatment with the possibilities that this will happen again, or preferable have an egg donation treatment. It's very difficult. It's very difficult. This decision is, well, it's one of the worst decisions that you have to make when you're in front of the patient. But well, as you can see, this is a very recent study, and even with these results, I would recommend that you go on with the treatment, because it's better to have an 8.4% of pregnancy rate and a live birth rate of 2.7 than cancel the treatment, because in that case you will have 0% of chances. But that's, I have to say, it's just me. Some clinicians prefer to say to the patient, well, don't get higher expectations and just cancel and do an egg donation. But not all patients are very receptive about the egg donation. On the other hand, there are patients that have an excessive response, where the most serious risk is the ovarian hyperstimulation syndrome. And as in these patients with poor response, the most important thing with this type of patients is to make an adequate counseling and decision making with respect of continuing the treatment, or do the oocyte retrieval and canceling the transfer, or definitely canceling the treatment cycle. Giesinger et al. Carried out a study where they determined the threshold, like the threshold of 19 follicles above 11 millimeters on the trigger day, and this would cause, or this was the threshold to have a severe or a moderate to severe case of ovarian hyperstimulation syndrome. And on these patients, you just not count the follicles, but you just also have to see how the patient is. So the clinic is very important, or the symptoms of the patient are very important for you when you're doing this type of treatment. You need to check how many follicles she has, and also if she has free fluid in the cul-de-sac or ascites. And in these patients, you should take measures to prevent the risk of having a moderate to severe case of ovarian hyperstimulation syndrome. So you should, maybe you should change the protocol, or do an antagonist of GnRH protocol with a trigger of agonist of GnRH instead of HCG. You should also coasting. Coasting is another type of treatment or measure that you can use to prevent ovarian hyperstimulation syndrome, or sometimes you even have to cancel the whole treatment. There are other questions. When you do the ultrasound, there are other questions as whether it is necessary to measure the follicles in 2 dimensions or three dimensions, and whether it is necessary to rely on ultrasound and serum estradiol may be a better determinant of the risk of ovarian hyperstimulation syndrome. As this study carried out by Martin et al. Shows, there are no difference in performing ultrasound follow-up versus ultrasound follow-up plus hormonal study. As you can see in the first part, when you compare ultrasound plus hormonal study versus ultrasound, the diagnosis of ovarian hyperstimulation syndrome was not different. Neither was the clinical pregnancy nor the miscarriage per clinical pregnancy rate or the number of oocytes retrieved, which means that we don't recommend that you do an estradiol testing as a diagnosing tool. And also, when there's another part of this study that compared the 2-dimensional ultrasound versus 3D-dimensional ultrasound or 3-dimensional ultrasound. And this study, the clinical pregnancy rate per woman was almost the same, but the quality of evidence is very low. So also actually they recommend that higher or better studies should be done to see if this conclusion they make is a good conclusion. But the thing is that the 3D ultrasound, it might not be possible to do it in every patient consultation. So when you just have the 2-dimension or the ultrasound and you're in your office, in your medical office with the patient in front of you, well, you don't have to do a 3D ultrasound to make a decision. So you can make the decision with just a 2-dimension ultrasound. Oh, sorry. This is also a Cochrane that shows no difference between the ultrasound follow-up or the ultrasound and estradiol levels to get higher pregnancy rates, higher number of oocytes retrieved per woman, the number of oocytes retrieved per cycle per woman, or the ovarian hyperstimulation syndrome rate, which means that you should not do estradiol levels to make decisions. So in this final slide of the presentation, I wanted to do a diagram of how we do the part of the ultrasound, or we do the follow-up of the patient when she's doing a treatment. So we do a first ultrasound when the menstrual period comes. On the first or the second day, we do the first ultrasound. We check the intrafollicular count, see how is the patient, check that there are no cysts greater or bigger than 12 millimeters, and we start the medication. It could be clomiphene, letrozole, or gonadotropins. There are different types of treatment that it's not part of this presentation. On the 5th to 6th or even the 7th day, we do another ultrasound to see the leading follicle. And we do another ultrasound between the 11th to 12th days after the start of the treatment to check how the follicles are going. And in case that the follicles are ready, we do the trigger. But in case that the follicles are not ready and you need a little bit more of medication or gonadotropins to get to those 18 to 20 millimeters, you just have to wait another 1 or 2 days. And then you do the trigger. And after the trigger, that in this case we do it with HCG, but we can also do it with agonist of GnRH in cases of risk or patients at high risk of ovarian hyperstimulation syndrome. We would do it with an agonist of GnRH, and 36 hours later we would do the oocyte retrieval. And well, after the outside retrieval, 15 days after, we would do the pregnancy test. So in conclusion, every treatment of ovarian induction, IUI, or COS needs ultrasound from the beginning to the end. Be prepared to do at least 3 to 5 ultrasound tests during the treatment, because this is your best tool at your disposal. You don't need the estradiol. You don't need anything else but your clinical criteria and the ultrasound. So after this, well, thank you. This is me and my group here in Bogota. And thank you all for your attention and hope to see you soon. Have a good day and bye.